Good afternoon, my name is Tom Lynch, student number 105796663, and this is my video exemplar for PST5107 Advanced Obstetrics for Paramedics, focusing on the management of the obstetric emergency shoulder dystocia in a woman experiencing labour from the second stage of labour through to the delivery of the placenta. So shoulder dystocia is an obstetric emergency caused by the impaction of most commonly the anterior shoulder, or less commonly the posterior shoulder, against the maternal symphysis pubis. Some risk factors for shoulder dystocia can include a previous incidence of shoulder dystocia, maternal obesity, fetal macrosomia, so a large baby, and gestational diabetes. Some complications of shoulder dystocia for the maternal side can include PPH, vaginal and perineal tearing and psychological trauma, and complications for the fetus, the baby, in the worst case scenario, fetal death, but also brachial plexus palsy and hypoxic brain injury. So we want to ideally aim to have shoulder dystocia resolved by, at the latest, the 6-minute mark. When we arrive on scene as paramedics, it's unlikely that we're going to know if shoulder dystocia was present beforehand due to its very unpredictable nature, but it occurs in anywhere up to 2% of births. So when we're walking in as paramedics, we're checking for danger. We've got our gloves on and our glasses on. I'm just stepping around here. We're going to introduce ourselves to the patient and gain consent, and we're going to be assessing for signs that the second stage of labour is underway. So signs of that would be contractions that are 2 minutes apart, 5 contractions over a period of 10 minutes, viewing the presenting part at the vulva/vagina, a bulging perineum, and a maternal urge to open bladder/use bowels. So the 2 key signs of shoulder dystocia that we're looking for. Thank you if you want to demonstrate the turtle head sign. So the turtle head sign is the big one, and it's caused by the impaction of that shoulder as the labour fails to progress. So with each contraction, the baby appears to be extending and retracting back into the vagina, as you can see here. The other key sign we're looking for is that the fetus fails to undergo restitution. So as I said, it's an obstetric emergency, so we want to have our equipment all laid out and ready to go. We've got our maternity pack here, we've got our monitor defibrillator. Just out of shot here, we've got our drug pack with all our assessment gear. We've also got our oxygen kit with neonatal resuscitation equipment. And out of shot behind me, we've got our minor and our major hemorrhage kits to manage any bleeding or complications. So we don't want to waste too much time, so we're observing the turtle sign. We're seeing it's failing to undergo restitution, so we want to act fairly quickly. I'm going to confirm to my partner, yep, we've got an incidence of shoulder dystocia. We're going to get onto our control, and we're going to request a second ambulance crew to attend, because remember, we've got 2 patients here, mum and baby. And we're also going to request intensive care paramedic backup because they have a wider scope of practice, more drugs, more interventions, and also more experience in dealing with obstetric presentations than general road paramedics. So there's a few manoeuvres we can undertake to rectify shoulder dystocia. We want to start first off with the external manoeuvres. So the first one we're going to do, you want to keep demonstrating that turtle head sign, is the Mick Roberts position. So what we want to do is we want to get an assistant or a relative or someone else on scene, or even the other paramedic, to bring mum's legs and raise them up to her chest, like so. We want to have an assistant continue to keep the legs positioned up near the mum's chest. Remembering these manoeuvres can be distressing and embarrassing for mum, so while we need to act quickly and decisively, we also want to ensure we maintain maternal consent and confidence and preserve maternal safety and dignity as much as possible. Now, this resolves anywhere between 40 to 90% of shoulder dystocia cases. Today that hasn't happened. So the next one we're going to do, while we maintain the Mick Roberts position, we're going to move to suprapubic pressure. So I'm going to take my hand, I'm going to locate this just above the symphysis pubis. I'm avoiding putting any pressure on the fundus or the uterus because I can cause fundal damage, uterine rupture, PPH, and severe pain for the mum. So while the baby's going in and out, in time with the contractions, I'm going to press down, down, down on that maternal symphysis pubis. in an attempt to dislodge that anterior shoulder. And this is also often quite successful, but today we're not having any luck. So today we're going to move to the final external manoeuvre, which is all fours, or the Gascon manoeuvre. So it's going to be a bit difficult to demonstrate with this mannequin, but we'll do it. So we want to get mum up on all fours with her bum up in the air. It's not completely sure how this, or knowing how this manoeuvre works, but sometimes that movement is enough just to dislodge that shoulder. And if you want to keep simulating those contractions. Yeah. So today we haven't been so lucky. We've still got impaction. So what we can also add is some gentle downwards axial traction in an attempt to relieve that obstruction. Another point I want to make here is we don't want to waste too much time on the manoeuvres. We've only got a maximum of 6 minutes. So we want to spend a maximum of 30 seconds, but if that's not working, we're going to move on to the next one. So we've got no success today. So now we move on to our internal manoeuvres. So we get mum back on her back. And we're going to move on to the first internal manoeuvre, which is removal of the anterior shoulder. So if you want to keep simulating those contractions, paramedic assistant. Yep, perfect. So the goal here is to remove that shoulder. So with maternal consent and protecting patient safety and dignity as much as possible, I'm going to insert 2 fingers of my right hand up. I'm going to attempt to locate that anterior shoulder and bring it down, down, down in an attempt to dislodge. As you can see, that is successful here, but today we're not so lucky. So put that back in. And the next one we're going to do is our wood screw manoeuvre. So again, maternal consent, I take 2 fingers of the right hand, yep, keep simulating those contractions, and I find the anterior shoulder, 2 fingers of the left hand, and find the posterior shoulder, and I'm attempting to rotate the patient just a little bit further out. A little bit further, no. So continuing to demonstrate the wood screw manoeuvre, we've got the contractions ongoing. A little bit more out, please. A little bit more out. Yep, just there. So we're going to take 2 fingers of the right hand with maternal consent and locate that anterior shoulder, 2 fingers of the left hand and locate that posterior shoulder. And the aim here is to rotate that baby 180 degrees to relieve the obstruction. So 1, 2, 3, and we rotate baby 180 degrees, as you can see. And as you can see, we're not having too much success, so we're going to do the reverse wood screw manoeuvre. 2 fingers of the left hand to the top on the same side, just in the reverse manner. 2 fingers of the left hand to the bottom, posterior and anterior shoulder. And with the contractions, we're going to rotate the baby in the opposite direction, 180 degrees, as you can see there. Now, if those manoeuvres don't work, there is a final manoeuvre that we can try. It's called removal of the posterior arm. There is some evidence to suggest that this should be the first manoeuvre that's tried. So again, maternal consent, we've got those contractions ongoing. I'm going to insert 2 fingers of my right hand in. I'm going to locate, while supporting the baby's head, I'm going to locate the posterior shoulder, and I'm going to attempt to flex it across the baby's chest. And there we go. As you can see, that's successful in relieving the obstruction. So now what we're going to do, we're going to pop baby up onto mum's chest immediately, and we're going to cover baby up with a blanket, mum and bub, to protect the baby, prevent heat loss. And then we're going to complete our APGAR at 1 and 5 minutes to determine newborn activity and the need for resuscitation. We're also going to keep an eye on the fundus height, view the perineum and the vagina with maternal consent, assess for any damage, place a peri-pad, and which will allow us to better estimate maternal blood loss, because if it's above 500 ml, we want to move down that PPH algorithm. We're also going to place neonatal SpO2 monitoring from our monitor onto the infant's preductal right hand and monitor those SpO2 values closely. We're going to encourage skin-to-skin contact and breastfeeding to promote the release of endogenous oxytocin. And we're going to, with maternal consent, because she may wish for a lotus birth, we're going to clamp at 10, 15 and 20 centimetres on the cord and cut between 15 and 20. Ideally we want to delay cord clamping for a little bit. And then again, we need to talk with mum. We want to exclude any allergies, any possibility of undelivered fetuses, and we want to administer, again with maternal consent, because she may wish for a natural placental delivery, 10 international units or 1 ml of synthetic oxytocin to promote uterine contractions and promote placental delivery and reduce the risk of PPH. We're going to complete full sets of maternal and neonatal observations every 10 to 15 minutes, inclusive of heart rate, SpO2, blood pressure, rest rate, fundal height and blood loss. And we're going to transport mum and bub together, ideally in the same ambulance, to a hospital with obstetric capabilities, pre-notifying as appropriate. And that's how you manage shoulder dystocia. Thank you for your time.